It's my pleasure to introduce our next speaker, Professor Jasna Mihailovic, who's the head of Department of Nuclear Medicine at the Oncology Institute of Vojvodina in Serbia. She's also full professor of the Department of Radiology at the Medical School at the University of Novi Sad. She's a former president of the Serbian Society of Nuclear Medicine, and I'm not going to be able to read everything on her CV here. It's very impressive. She's at several international fellowships. She's a member of the Thyroid Committee of the European Association of Nuclear Medicine and has numerous publications and has written several book chapters. So Professor Mihailovic, it's a pleasure to have you.
Thank you very much. First of all, I would like to thank to the organizing committee for this invitation. And this is actually the huge topic I will talk about, but unlike the previous speaker, I will try to cover it as much as possible. Pediatric differentiated thyroid carcinoma is a rare malignancy. It accounts about 1.5 to 3% of all childhood carcinomas. Papillary thyroid cancer accounts for about 90% or more of all childhood cases. The major risk factor for developing PTC is radiation exposure to the thyroid. Children, and especially those who are younger than 5 years, are the most sensitive. Pediatric DTC has aggressive initial presentation. Between 60 to 80% have cervical nodal involvement, which is associated with distant metastasis. It usually has a good outcome, and comparing with mortality in adults, the overall mortality rate in children is not increased. However, the recurrence rate is high. There are only few guidelines which were published on that topic, and as you can see, German Society published in 2007, and American Thyroid Association published in 2015, and just recently, last year, it was released, this one, issued by the European Thyroid Association. I will cover as much as I can from ATA guidelines, and afterwards I will show you some Serbian experience on that topic. So pediatric DTC is usually treated the same way as in adults. Management includes primary initial surgery, radioactive iodine, and LT4 treatment. For the majority of children, total thyroidectomy is suggested. Total thyroidectomy compared to lobectomy has been shown to decrease for persistent or recurrent disease. In patients with preoperative evidence of central and or lateral neck metastasis, a therapeutic central neck dissection should be performed. In every patient, postoperative risk classification should be done. In adults, the AJCC-TNM classification system is the most widely used. However, due to the extremely low disease-specific mortality in children with PTC and the fact that all patients aged less than 55 years have either stage 1 or 2, TNM classification system is limited for prognosis in children. Despite that, this classification system is an excellent to describe the extent of disease and to stratify an approach to management of pediatric DTC patients. This is the latest 8th version of TNM staging system. I'm sure all of you know. And based on clinical presentation, tumor size, and presence of regional and distant metastases using the TNM system, children with DTC are stratified into 3 different risk level groups: low, intermediate, and high. This categorization strategy does not define the risk of mortality, which is, by the way, low for both 1 and 2 stage, but identifies patients at risk of persistent cervical disease and helps to determine which patients should undergo postoperative staging to screen the presence of distant metastasis. The extent of disease in the neck at diagnosis appears to correlate best with the risk for distant metastasis and or persistent disease that may require additional treatment. These are different risk level groups which I previously mentioned, and within these categories, additional postoperative staging is warranted to better define which patients may or may not benefit from additional therapy. Initial postoperative staging is usually performed about 3 months after the surgery to assess for evidence of persistent locoregional disease and to identify patients who are likely to benefit from additional treatment with radioiodine. The individual patient's risk level helps to determine the extent of postoperative testing. As you can see, low-risk patients should be surveilled only with a TSH-suppressed thyroglobulin alone, while TSH-stimulated thyroglobulin and diagnostic whole-body scan are recommended to assess for evidence in intermediate and high-risk patients. This is initial postoperative staging for intermediate and high-risk pediatric thyroid cancer, and you can see that this is pretty busy slides. I will not go into details, but I will just say a few things, that it is assumed negative thyroglobulin antibodies, and in thyroglobulin positive patients with exceptions of T4 tumors and clinical distant metastatic disease, we should allow some certain time for thyroglobulin antibodies clearance, and we should perform delayed staging. Imaging actually include and should include neck ultrasound and SPECT-CT. If some patients had detectable and resectable disease, they should be sent to surgery, and after every surgery, 3 to 6 months, we should repeat this postoperative staging. What is the goal of radioiodine treatment in children? To decrease the risk of recurrence and to improve mortality by eliminating iodine-avid disease, and it is important to reduce or eliminate unnecessary radioiodine exposure for children without increasing disease-specific mortality and disease-specific mortality. The indication for radioiodine therapy is iodine-avid, persistent locoregional or nodal disease that cannot be resected, and patients with known or presumed iodine-avid distant metastasis. In patients with persistent disease, we should have individualized approach according to clinical data and previous response. Patient preparation usually include everything what we do for adults, certain TSH level, withdrawing LT4, and RH-TSH should be considered in some patients, and low iodine diet. Radioiodine activity may be adjusted for the body weight, patient's age, 24 hours thyroid bed uptake, and body weight. And we should keep in mind some other issues like longer life expectancy, higher sensitivity to possible complications after the treatment, smaller body and organ size resulting in greater bone marrow and extrathyroid tissue radiation and higher cross radiation. Usually the first activity of radioiodine is based on empiric method by using fixed activities, and dosimetry should be used for diffuse lung metastasis or patients with iodine-avid distant metastatic disease who need several additional treatment courses. Dosimetry can be also considered prior to the first radioiodine treatment in small children and children with limited bone marrow reserve. Post-therapeutic whole body scan must be done in every patient, and we shouldn't treat any patients with radioiodine unless we perform post-treatment whole body scan, which is really must do, Holy Bible. This is how we keep patients on TSH, different levels of TSH suppressions according to the different risk groups. This is also pretty busy slide. I will not go into details. It shows management of patients with known or suspected residual and recurrent disease without known distant metastasis. Management of patients with known distant metastasis is also shown at this slide. And now I will just go briefly through the possible short and long-term side effects after the radioiodine therapy, which all of us know about that. These short-time side effects include several side effects, but they are also usually mild and transient. Most frequently is sialoadenitis, but we should use some preventive measures like lemon drops and hydrations of the patients. And postpubertal testes, they are more vulnerable than prepubertal testes, so sperm banking is recommended. Acute suppression of bone marrow may occur, but usually it is transient. Long-term side effects, actually in our experience as well, we had only pulmonary fibrosis, and there is actually the significant risk in those patients with lung metastasis if retained activity exceeds 80 millicuries. Therefore, in these patients, whole body dosimetry is recommended to calculate the largest activity of iodine that can be administered. Absorbed activity to the blood does not exceed 200 centigrades. Whole body retention 48 hours after administration does not exceed 120 millicuries in the absence or 80 millicuries in the presence of radioiodine diffuse lung metastasis. We also can perform lesional dosimetry. And another issue is regarding secondary malignancies. We know that radiation-induced malignancies develop after certain latency times of several years, between 2 to 3 years for hematological malignancies and approximately 5 years for solid cancers. And there are actually several important publications done on that topic. Famous publication of Brown covered 30,000 subjects of all ages, and actually it found a significant increase in second malignancies among patients treated with radioiodine, but the risk was greater for young patients. Hay also made some publication in 2010, and he found that children treated with radiation, including external beam radiation, radium implants, or radioiodine therapy, developed variety of second malignancies and had increased mortality compared with the general population. This is one publication that actually we published 3 years ago by now, and it was a multicentric study. It covered 10 different European countries with their own results, including, of course, Serbian results. I will show you later on our publication, which we published in Journal of Nuclear Medicine, American Journal in 2014. And actually, we evaluated bidirectional association of DTC and breast cancer, but the conclusion of our paper was that radioiodine does not influence the lifetime risk of breast cancer after DTC. It is actually difficult to determine if there is a safe cumulative exposure to radioiodine or if the increase in second malignancies occurs following any amount of radioiodine. Another issue which complicates this question is the fact that the effects of radioiodine may be amplified in children because a given activity of iodine is distributed over short distances, taken up by smaller organs, and accumulated by cells with increased growth and proliferation potential. ETA guidelines, it was published last year, and I was just analyzed and did not see much differences with ATA guidelines. They have, besides recommendations, they also included suggestions, but overall, it was pretty same as ATA guidelines. They also suggested multidisciplinary tumor board to talk and discuss about activity, and also they included the same criteria for complete remission. This is Serbian experience. I will just go through it very quickly. Institution where I work was the only facility in Serbia for radioiodine treatment until 2006. We analyzed recurrent disease in children, and actually we found it and detected in 22% of patients. The factors that were strongly predictive of recurrent were age, initial treatment, and tumor multifocality. The probability of recurrence was 17% at 5 years, 22% at 10 years, and 33% after 15 and 23 years after the initial treatment. Among 51 patients that we analyzed in that publication, 11 females ultimately had children, and we did not detect any secondary malignancies. Finally, to conclude, the first activity of radioiodine should be based on empiric method by using fixed activities. Dosimetry should be performed for diffuse lung metastasis. Recurrent disease should be treated with surgery and radioiodine treatment until remission. In patients with extensive lung metastasis, there is concern about high radiation absorbed dose to the lungs, and dosimetry should be performed. If retained radioactivity in the lungs exceeds 3 gigabecquerels, the dose should be reduced to avoid the risk of radioiodine-induced lung fibrosis. Post-treatment whole body scan must be done. Both initial treatment with radioiodine and additional treatments with radioiodine are safe with no adverse effect on fertility and secondary malignancy. Now I will finish with that, but please let me just announce this meeting. My friend from Miami, Professor Cesar Gulek, he kindly asked me to announce this Miami Thyroid Oncology Symposium. It is dedicated to thyroid cancer specifically, and it will be a hybrid symposium, in person and virtual, and there is his email. You can email him if you are interested, and this is some topics which will be covered 2 days, Friday and Saturday. This is the Friday, and I will also be the speaker in person there, and this is the Saturday. Thank you very much.
You go like this.